So what I'm going to really talk about is what does that mean for practicing obstetricians in terms of trying to figure out what are you going to do about the science. Our program was founded on a patient's question. So the director of our program and the founder of our program is Dr. Patrice. She's the head of the Department of OBGYN at UCSF. And I guess maybe about 10 years ago now, Dr. Patrice had a patient. She's a fertility expert. And her patient said, I grew up near a toxic waste site. Is that the reason that my fertility is problematic? And Dr. Patrice didn't know, because she had had no training, and she said it was really a wake-up call for her. And from that patient's question, then there was a summit on reproductive health and the environment in 2006, and then subsequently our program was founded. So I think you've heard many ideas today about what obstetricians and gynecologists can do. In this case, OBGYN heard the question, gee, I grew up near a toxic waste site, and this whole program is the result of that question. So I guess you already listen to your patients, but you can really see what you can do with that information. So our mission is to create a healthy environment for reproductive health, for human reproduction and development. And we do that. We conducted a lot of basic research. And when Dr. Soto was with us, and now she's at GW, she was part of the team. And we do particularly a lot of basic research on fetal exposures to chemicals. Oops. But my work in our program is about how do you act on the available information. So we have a lot of data, you've heard a lot about how the environment affects your patient's health today, but then the issue is, well, what are you going to do about it? And so I am the head of the Community Outreach and Translation Corps. And typically, communities are geographic communities, but in our program, you're our community, which is why it was a delight to come and travel here to talk to you today. Because what we're really trying to do is to normalize environmental health in healthcare. So we have an approach which different speakers have kind of touched on, but it basically involves action on the individual level. So for example, talking to your patients about a healthy food system and healthy diet and things that individuals can do. It also encompasses working with many partners like Physicians for Social Responsibility and Healthcare Without Harm to have health providers work within their institutions to leverage the enormous potential of healthcare institutional change in terms of affecting a healthy environment for your patients. And then, as has been talked about in a variety of ways, there's only so much that individuals alone can do, and there's only so much that the institutions can do, and in fact, we need to affect policy change. And for those of you who are in Dr. Zoder's breakout group, she talked there were a lot of good examples, some being just getting phthalates out of toys and then seeing population level phthalates decrease over time. So I will be learning how to use this shortly. Okay, so what you've heard a lot about is, in fact, why is what you're doing so important? Because as was talked about this morning, you know, by the time the pediatricians get these babies, it can be too late. So you have the opportunity to intervene during the time that's going to affect your patient's health throughout their lifetime. So in fact, I was thinking when I was listening to the talks that really, you know, at my age, I should be really thanking my obstetrician at this point because your time with your patients is such a critical point for the rest of their lives. As I said, I will be learning this. Okay, so you are not the ostriches. Dr. Henry started out talking about ostriches. We had talked more than to reduce patient exposures, but less than a quarter are taking an environmental health history. And what do obstetricians ask about? And I bet this is true for, well, you can tell me, okay? Is this true for you? Do you always ask about diet, alcohol, and smoking? Everybody asks about that. So I've heard. Okay, but the obstetricians we surveyed, less than 20% of them really talk about chemicals in their environment, whether it's pesticides, phthalates, chemicals that actually have very strong evidence of harm. They are not really talking about those chemicals to their patients. So is there anybody here who talks to their patients about toxic chemicals?
If they ask.
Pardon?
If they ask.
If they ask, and so we did focus groups of doctors in the San Francisco Bay Area, and actually one of the key drivers, I think, of integrating environmental health into OB is that there's, depending on the patient population, there's a lot of pressure on the docs to answer questions. And some of the barriers and some of the challenges, I think have been already talked about today, is basically you have a very short time frame and you have a lot of, you're doing a lot of prioritization for your patients. And so one of the things in our focus group, someone said, well, the person has the plastic PET bottle, but there's Coca-Cola in it. So which is the thing I'm supposed to be talking about at this point? So there's a lot of bigger fish to fry. And the other thing is that just about like all of us, people really don't want to ask a question that they don't know an answer to. And so it's kind of like opening up Pandora's box. And I would just here put in a plug, one of the reasons that we are so committed to strengthening the pediatric environmental health specialty units is because there are people, which you all know today, but didn't necessarily start out knowing, there's resources out there for you to be able to ask questions because basically you can call Jerry. And so.
Oh, thanks.
I heard you. You started out today saying that, Jerry.
Okay.
And of course, the reason that it's a Pandora's box is because there's very, very, very little to no training in your medical education about these issues. So there's a lot of challenges ahead, and the question we then ask is, well, what is an OB supposed to do? The science is voluminous. It can look conflicting at times. You kind of get it in headlines like this day this is good and this day this is bad, and it can be very confusing, and unless it's something, even if it's your field that you're working on, it's completely difficult to really keep up with what the science says. And you can also get into this kind of thing like this study said this and this study said that. So how do you know really which study is right, aside from the fact if Ami or somebody else did it, then you know it's right. But basically, you have a lot of information in bits and pieces that it's very hard to actually figure out what's important for your patients. So this is an artist's conception of what it might feel if you're an OBGYN to be kind of jumping off a cliff into environmental health. So we're here to help. So in the clinical sciences, a lot of these challenges have been already addressed, and I just wanted to take a moment to see who among you have ever conducted a systematic review? Who has ever read a systematic review of the evidence? Oh, good, okay. Who among you have heard of the Cochrane collaboration? Great. So as you know, and as I think that you were saying in terms of younger medical students, this is what you're kind of trained on, is evidence-based recommendations. So one of the foundational tools that we're hoping to help develop for OBGYNs is evidence-based clinical guidelines. And so we're feeling that if we want you to, we think environmental health is, that's what the science says is very important, it needs to look like the evidence that you're used to using in your practice. Just a little bit of history in terms of evidence-based medicine. In 1992, so there was a day, which I guess some of you, but not many of you, might recall, there was a day in clinical medicine where basically expert-based reviews was how people found out what to do. But in 1992, there was a paper published in JAMA by Antman and colleagues, and it really took a look at what is the reviews versus doing systematic reviews. And this was really kind of the watershed moment, this paper, because it showed that for some treatments, experts were recommending things that were not only not efficacious if you looked at the evidence, but they were downright dangerous for patients in some cases. And then this was really the initiation of the Cochrane collaboration and a whole new era in clinical medicine where people were developing methodologies to integrate the science as it was produced in a timely manner for clinicians to be able to take advantage of. So evidence-based practice is applying the best available research results when making decisions. This is a definition from AHRQ, the Agency for Healthcare Research and Quality. And basically, it's not just about science, as you all know as practitioners, it's about the values and preferences of your patients at the same time. And systematic reviews are a methodology that help get to this point of being able to talk to patients about what the evidence says and what does it mean for their health. So we started out thinking, well, that's great. We'll just use those methods. But the methods that are used in clinical medicine, because of a few issues which I'll talk about, is not directly applicable to environmental health science evidence base. And Dr. Connery was kind of alluding to this and talking about this a little bit in her talk this morning. So we had a headache. What were we going to do? One of the reasons that the science is not directly applicable is in environmental health. We rely enormously on animal and other toxicological data. That is a signal of early warnings. And as the cartoon says here, your research is very promising. You should do it with a shame you're afraid of mice. And as clinicians, people are trained to look for a randomized controlled trial, and that is what we consider the gold standard, as it should be in clinical medicine. But in environmental health, animal studies are the early warning signal. If you wait 20 years to do a human study to look for adverse health effects, then you have lost enormous potential for prevention. So fear of animal studies in terms of not appreciating their value in environmental health. And also, as Jerry was saying, in environmental health, you really can't conduct randomized controlled trials because they're basically ethically precluded. I always say at this point, though, of course, we are doing the experiment. We're just not collecting the data because, in fact, everyone is exposed, and but they're not exposed in a way that you would conduct an experiment. So why does she have a parachute on that slide? Well, the reason is just to point out to you, you don't need a randomized controlled trial for decision making about things like whether or not there would be an adverse effect from jumping out of a plane without a parachute. So another thing just to instill in you is that you don't need an RCT for every decision. So this gets to a more map of the difference between streams of evidence in clinical medicine. And I know that Veronica said that there's a pointer here, but I couldn't really see I couldn't see the red dot. So now just everybody look on the left-hand side. For you guys over here, it's over here. And you can go down the line on the clinical side and see that first a new drug is developed, and there's in vitro and in vivo testing, and then it goes to human experimental studies, it enters the marketplace, and then you look for health effects that you might see once you're exposing a large population to the drug. GRADE is a system that is a Cochrane-like, which, has anyone heard of GRADE? Okay, so GRADE is the grading of recommendations, and oh my goodness, I should have read it while it was on the slide, but it's an acronym for basically, GRADE is a system that's like Cochrane, and the difference is that Cochrane reviews never make a recommendation, they just tell you what the science says. But GRADE goes further and grades recommendations for prevention. This is all on the clinical side. So, what's the fundamental thing about the clinical side, which, by the way, I'm not at all saying it's a perfect system on the clinical side, but conceptually, you're basically studying something before the exposures occur. In environmental health, we have a completely different decision context. So when you're thinking about talking with your patients, it's a very different risk-benefit because, in fact, number one, environmental chemicals were not necessarily designed to have a health effect one way or another. The exposures occur because it's fulfilling giving a pharmaceutical or other intervention with our patients. But all of the context is that your patients are exposed. So you're deciding what is it that you need to act on to take away those exposures. It's really the world upside down. Because in environmental health, basically all those chemicals that we've been talking about today, in 1976, when the Toxic Substances Control Act came about, 62,000 chemicals were grandfathered in, and then there's been a very limited assessment by US EPA, which is the agency that regulates chemicals in commerce. So pretty much, virtually, the vast majority of all of the chemicals in the environment that your patients are exposed to, we really don't know very much about. They have either limited or no toxicity testing. So it's a very different decision context. These chemicals enter the marketplace, and then all of the work that we saw from Dr. Ferrer and other speakers today, it's all after the fact to then demonstrate whether there's harm. So it was alluded to in the breakout group about there's currently some legislation around to reform the Toxic Substances Control Act under consideration. And actually fixing this policy is a huge policy, would be a very important policy gain. But at UCSF, we of course take no positions on any particular piece of legislation because we are a government agency at the University of California. But one of the points that Dr. Conley made this morning was this need to change the burden of proof. And I would say that a good policy to affect your patient's health would be chemical policy reform that switched the burden of proof. So as Dr. Conley put this morning, it's not on you and your patients to have to figure out if this is causing them harm, but on industry and the people who put the chemicals into the marketplace to prove safety before your patients are exposed. So that leads into the navigation lab. So we are basically trying to adapt methods that are used in the clinical medicine to the decision context and to the evidence stream in environmental health. And all of the work that I'm talking about was a very big collaboration of many people, both clinical and environmental health scientists. We began in 2009 to develop an evidence-based medicine methodology to basically bridge this gap. And this is an overview of the methodology, so you have to all remember it. There's going to be a test. But it's really very simple. You have to specify a study question, select the evidence, and then you rate the quality and strength of the evidence, and then you grade the strength of the recommendation. And we I'll just leave you with that context for the moment. So we developed this method based on the best practices in environmental health and clinical sciences. And then these are the colleagues at UCSF. Dr. Woodruff, Tracy Woodruff, is the director of our program at UCSF. We also have other folks at UCSF as well as US EPA and Johns Hopkins. Karen Robinson of Hopkins is with the Evidence-Based Practice Center there. So we had a large collaboration of folks to basically see, well, now we have this method, does it work, and how can it be applied? And so we developed the first case study to see proof of concept of the method based on PFOA. And this is, we're talking in my breakout, on this breakout group about PFOA. PFOA is a chemical that is helpful in that it gives the quality of grease resistance to various things. So fast food, packaging, Teflon frying pans, and the joke is that it goes out of the frying pan and into the panda. So it's late, I know. So, but anyway, it's probably because it's manufactured that the chemical is basically everywhere, not so much really because it's coming out of your frying pan into you. Although, just a tip, I would use high heat on Teflon pans. But I digress. We picked PFOA because it is a high production volume chemical. It persists in the environment, and everybody is exposed, and I'm a systemic space. And also, there's some indication that it's related to fetal growth, adverse effects on fetal growth, and as I'll fetal growth is a very important public health measure. So for all those reasons, we conducted the first case study on fetal growth. As I mentioned, we basically looked to Braid and Cochrane as a guide. We did a lot of multiple people doing things to kind of make sure that we were accurate and reproducible. And I'm going to go through now kind of what the various steps are. So I know this seems obvious probably that you should have a roadmap and a plan and a protocol before you start to do something, but we don't normally do this in environmental health. So this is kind of a first step, is that you basically have an a priori protocol of what are the rules of the game. What are you going to use as rules for your analysis? And first thing is that you develop a P-code statement, and I'll give you an example of what our statement is. But it's basically saying this is the population I'm going to look at, this is the exposure, this is the control, and this is the outcome. And then you develop criteria for selecting studies. You select the studies, you extract the data, you analyze it. Are folks familiar with the idea of risk of bias? You are. Okay, so risk of bias is completely new to environmental health. So just so, because I'm thinking you're going to think this is normal, so why is she talking? But this is not normal for environmental health. And then you do these ratings. And now I'm going to just very quickly go through kind of what the results are. But I just would say if you have any questions or comments before I keep yakking. Okay. So these are, you have these slides. But basically our question was specifying the study question, does developmental exposure to this chemical affect fetal growth? So what's important here is to see that you have a different statement for both animals and humans, because once again, we're looking at all of the data. That's a very novel thing in environmental health. We will ultimately integrate what the findings in animal and human data are. You select the evidence, we had a very systematic approach. You decide what's in and what's out. So if studies didn't have original data, there were no human or animals in them, there was no PFOA exposure, it seems kind of self-evident, except that we don't usually approach our reviews in environmental health this way as much as we rely on expert-based narrative reviews. So this is just to give you the schematic, is that we basically found about 6,000 studies both in between animals and humans, and you go through the hoops, you get rid of duplicates, and then you see which ones meet your inclusion and exclusion criteria, and we ended up in the animal side with 22 studies, which were 32 different data sets, and on the human side, 18 studies and 19 different data sets. And then there were subsets within each of the animal and human data that we were able to analyze using meta-analyses. So then you rate the quality of evidence. So the first thing you have to do is look at the studies and decide as individual studies what biases might be in them. And I just want to make the point here that bias or risk of bias is about systematic error in one direction. It is not precision. It's not about how close you can know the truth. It's whether you're actually looking at something that's the truth. It's about accuracy. Whereas random error could go in both directions. This is a schematic which shows you essentially what you're looking at. On the far left where it says risk of bias, you look at every individual study and you look at these various domains which from either toxicological or an epidemiological perspective can introduce bias into your results. And then you decide if it's high, low, probably, or possibly high risk of bias. The second step is to say, what's the quality of the body of evidence? Now, risk of bias is only one aspect of that. You also consider whether it's direct evidence or indirect evidence. Is this directly applicable to humans, etc.? And then you put it all together to decide what the strength of your evidence is. And you do that for animals as well. And you have the slides so you could look at the different criteria. They'll be familiar to you, anybody in research, but what it does do is transparently show what the judgment that you have applied to each of these factors are. So these are the results from the PFOA case study. On the right-hand side is methods to toxicology. And then we're able to conduct meta-analyses. And what's important here is that if you look at the human data, the straight line down the middle is kind of if there were no effect. And the little boxes that are on the left-hand side, in this case, show that the effect measure is pretty much in a negative direction, meaning that the more PFOA exposure you have, the lower birth weight you have. So you're having an inverse relationship on birth weight. And the bars that go across are your confidence intervals, so it's kind of showing you, how much confidence did you have in that estimate. The thing I also just want to point out is that the size of the boxes show you how much that study contributed to the estimate. So you can look at these forest plots and you can kind of see how the studies kind of fall out. And the bottom line here is that for both the human and the animal data, when you combine the studies in meta-analysis, PFOA exposure adversely affects fetal growth. So what does that mean to public health? Well, Paula Johnson, who's the epidemiologist on this project, kind of looked at what the NHANES data were and how much PFOA exposure across the U.S. and birth weight, and thought if you just shifted the curve, the distribution of exposures in the United States based on what we know as baseline, in fact, it's a pretty significant public health impact because it would give you a reduction in the proportion of low birth weight babies in the U.S. of about 1%, or about 40,000 babies a year. So basically, you could look at it the other way. If you took the exposures away, you'd prevent that many low birth weight babies. This I'm going to just skip quickly through, but essentially to say there's a system for rating the quality of evidence. We start out with moderate evidence for human and high evidence for experimental animal studies, and you then add that to considerations such as what was the direction of the effect, what's your confidence in the effect, or other compelling issues. We come up with, in the case of PFOA and fetal growth, that there was sufficient evidence of toxicity in both animal and human evidence streams. So then you have to put these together, and that's something that's very novel and is not done in clinical medicine. And when you put them both together using this table, which we used from the International Agency of Research on Cancer, you come up with the finding that human exposure to PFOA is known to be toxic to human reproduction and development based on sufficient evidence of decreased fetal growth in both human and non-human mammalian species. So what we're hoping is that that would be a good bottom line for a clinician, to have that kind of information where if you were interested, you could trace it back. So essentially, it works. So this is the first time someone's tried to link the data in this way to a bottom line. I mean, there's plenty of bottom lines in the literature, but you just can't trace them back very well. So one of the next steps will be to actually get into the idea of making a recommendation, because the toxicity of the chemical is only one aspect of what you want to talk to the patients about. A good example is, so in clinical medicine, as you all know, you can make a very strong recommendation based on these data. And so because there's another alternative. So one of the most important applications of this method is to actually find and identify things that are safe. So a good example would be when you get to recommendations is you can right now, without really having a lot of evidence around whether X, Y, or Z cleaning product is toxic, you can make a very strong recommendation to not use those products because in fact there are very safe alternatives to toxic cleaning or potentially toxic cleaning products. People can use vinegar and water, baking soda. So here you have a strong recommendation even in the absence of a lot of science. So I'm now going to switch, now that you know where clinical guidelines will be coming from, hopefully in the future, just to see if you have any questions, and I was just going to talk about some additional resources.
So, how do you view this building out over time in terms of the scope of the effort and prioritizations for which things get analyzed and that sort of thing?
Right. So what we're doing is really trying to develop the methods. Really what needs to happen, and it is happening, is that the National Toxicology Program and the US EPA will start to use these methods. And so the National Toxicology Program is actually developing methods very much like this. It's kind of, what we've done is really establish proof of concept of what they're going forward with. So you really need to enlarge institutions that have the infrastructure to really analyze chemicals to do this. So NTPs going forward, the USCPA has kind of moved from considering, well, they were kind of like, they've been forced because there's a lot of outside criticism of USCPA, which much of it's coming from the chemical industry. So not such necessarily from a good place, but their IRIS program, which is the program at USCPA that basically you would look to as health professionals for what did they say about the chemicals. That program does really great work, but they have been criticized because it is not possible to really know how they reach their decisions. And if you try to read an IRIS report, it's kind of true. You kind of can't really exactly tell how they got there in some cases. So they could get the right answer, but they were severely criticized by a National Academy of Sciences panel that reviewed their findings about formaldehyde. So they are responding to external drivers of change. So I think the hope is that these institutions will start to develop more robust methods, because there's, and particularly robust methods for determining what might be safer, because a lot of the talk, certainly Ami's talk, was just about the replacements for flame retardants are perhaps more toxic, and the same is true for BPA. And so the idea would be, if you could prioritize by figuring out how you could do something better and kind of get off the conversation about how toxic this Y or Z, as much as what kind of information do you need to know to tell your patients, like with the cleaning chemicals? You know, you can really make a very strong recommendation today. So kind of to use it in that way. There's a lot of, should I answer your question? Yeah.
Yeah, so this is Deborah Patrice Sutton, University of Rochester. EPA now has a chemical advisory committee for IRIS, chemical assistant something, I can't remember, I'm on it, but it has a strange acronym. And a new director, of course, for NCEA, who's Ken Olden. And the goal of this, ostensibly, is to make IRIS more transparent, faster, etc. Have you had conversations with Ken?
Yeah, we've met him several times. And Tracy, as you probably know, there's another NAS panel that's led by Jonathan Samet, so she presented her findings in detail to them. And of course, we're not part of that panel, but from what the questions are in the discussion at those meetings, it's hopeful that that NAS panel will come out and recommend systematic methods. And so I guess we're hoping that kind of the example out there. It's not just, I mean, by the way, you know, way more than I do about risk assessment, but it kind of looks simple when you see that there's a 1,000 things embedded in here, which I just want to be a flavor for, to get you kind of get a grasp of the evidence stream. But there's a lot of things to work out. There's a lot of new kinds of evidence in environmental health, like in vitro testing, and that like risk of bias is never really figured out. So there's research, methodological research questions, particularly if you want to do results screening and things like that. But it's a framework, and the framework has 2 decades of empirical basis, basically clinical sciences. So I don't want to be gene sensation substances for Pollyanna. I don't know that I'm any of that, but there's a lot of interest and there's a lot of external drivers. And yeah. So, and there's actually some champions. And one of the things that we're working on with this, so first of all, there's participation. First was the IRIS program. But even within IRIS now, we're going to be looking with them just to look at risk of bias for the aesthetics, to try to really refine that too. One of the things is that we want to see right now the MAP and others. We had worked for, since our inception 5 years ago, to develop they're evidence-based in the sense that they're good recommendations. And also, though, what I guess I really want to point out is that if you go online, these are linked to hundreds and hundreds and hundreds of other recommendations and things, so you can update them all the time. And the green book, which I guess I'm going to get to, and the green book's coming up. But the point is that there's a lot of resources that have been developed, like by the American Academy of Pediatrics, that are really useful for you today. And on our website, we link to all of these great resources. So it's a place that your patients can go. I also just wanted to say, if you're feeling alone, you can go to our Professional Society Statement Database, because in fact, many, many health professional societies have weighed in on these issues in various ways. And so for those of you who might be in institutions who want to be able to demonstrate that you're not really asking the institution to jump off a cliff, in fact, there's a lot of support for these issues who go there. This is the green book, which I think was mentioned, but I just want to say, so our brochures had their origins in the Physicians with Social Responsibility Pediatric Environmental Health Toolkit, which was endorsed by the American Academy of Pediatrics, and it was kind of it was just kind of translating that. So those were made before the new green book, but they're kind of all related, I guess. And there's tools. The tools are more geared for. They're directed in the language towards pregnancies, but as you now know, at the end of the day, it's fertility. So one of the things that we've been doing also to translate the science is putting a lot of work in the literature that OBs have read, although I wonder if any of you have read any of these things, because in theory, you're to go to your journals and textbooks. And with that, I will close for questions. I just also want to acknowledge, I already mentioned Dr. Jadis and Dr. Woodruff, and we have all the work that I'm showing you is actually part of a wonderful team of folks whose names are there. Questions, comments?
I'm Abby Nerlinger. I'm a fellow at Children's National in hospital pediatrics. So I think part of the problem with TSCA is I think this is a great approach for chemicals that we know something about, but can this framework be used at all in informing the research as we move ahead for all of the many chemicals that we don't know anything about?
The framework being the navigation guide method, or the framework being
the literature analysis method.
Right. So, I guess there is a way that we're going to have to make. So I guess there's two parts. So one is that until we switch to birth method, that someone has to do this research first, we'll never be able to keep up really. So there's kind of a fundamental policy gap. On the other hand, no matter what decision you're trying to make, you're going to look at the science to contribute something to it. And I didn't go through some of the time constraints and limitations, but there's a lot more than science that's going into whether you do something about environmental chemicals. But to the extent that science is involved, yeah, I mean, it's much more, in my opinion, of course, it's not totally tested, but sometimes, I was tested for 20 years, that's not necessarily scientific methodological issues. But you can, I mean, in the clinical field, people actually get answers when they're needed. It would be kind of unacceptable to say to a patient, well, I can't really tell you about the day, come back over time. You have to do something today, because we don't have that kind of urgency. I mean, some of us do, and curious about the environment, but, so to the extent that you want to inform decisions with evidence, then yes, I think there's a lot of I think that it's a way to give people a picture of what might otherwise look like a consistent data. One of the things I mentioned figure out why do you have like varying things, and you can't even tell by some of the reviews who's being